So moving on is the aesthetic complications that are reported, which is similar to, the single and multiple is around 10%, right? And I'm gonna lump aesthetics and phonetics and soft tissue hyperplasia and soft tissue issues all together, because it really depends on how the process is designed. And if it's designed properly, you can kind of really minimize all three of these things. So the prosthesis you have to look at, when we're designing, we're looking at occlusion, comfort, phonetics, and hygiene, okay? And if you look at any sort of full arch restoration, there's 4 surfaces of each prosthesis, right? The occlusal, buccal, lingual, or palatal, and the intaglio surface. And each of these surfaces control different things. Number one, which is the easiest, is occlusal, right? Occlusal is talking about occlusion and how you're gonna design the teeth. And so, obviously occlusion is very important. If you're designing the occlusion improperly, the chance of things breaking are higher, right? And and obviously there are going to be other issues related to occlusion. So we're doing these full arch restorations. Bilateral even contacts is a requirement or ideal. Canine guidance or group function, both are okay, depending upon what's on top and aesthetics and whether the patient bruxes or not. Anterior guidance, or actually more so, is making sure that the anterior doesn't encroach on the envelope of function. So anterior guidance is sort of like the inward out motion, or the inward out, or the envelope function is really kind of when the patient's chewing, the outward in motion, right? Whether chewing, the front teeth shouldn't be knocking each other, shouldn't be in the way of the function, right? And then kind of choosing the anatomy of your teeth. Is it going to be monoplane, 10%, 20%, 30%? And that's largely dependent upon what's on the opposing arch, right? If you're doing a lower fix restoration, the upper is a denture, you should be, and the patient has poor dexterity, for example, maybe monoplane teeth or 10%, 10 degrees teeth, because the upper denture is the weaker arch. So the occlusion is based upon the weaker arch. If the upper jaw is a denture, that's the weaker arch. The lower should be more flatter teeth. It may be bilateral balance. If the upper teeth are fixed in, you're treating the lower arch as a fixed case. You may want canine guidance. You may want more anatomical teeth. So that's the occlusal aspect. The next is the buccal aspect of the prosthesis, and that's responsible for aesthetics and the anatomy, but also hygiene, okay, and making sure things don't have ledges, so people don't have things getting stuck between the prosthesis and the gums. And that meaning like no ridge laps, no overhangs, stuff like that. And then staying within the neutral zone. So the neutral zone is basically a zone where your teeth can coexist. And if the teeth in the prosthesis is beyond this zone, the patient is going to constantly bite their cheek or their tongue, okay? So this is concept from dentures, right? Like all their teeth should be in this zone between your lips and between your cheeks and your tongue, so that you don't bite off your cheek or tongue, okay? When you're designing these prostheses, you need to follow the same denture principles here. So the buccal aspect is also in chart, and obviously important in lip support, right? Supporting the lip and the face. That will also influence how patients speak and how they look, how their face is going to look. It obviously is going to be important in changing, in controlling the color of the teeth, the color of the gingiva, and the overall smile design, right? Clearly, the buccal aspect is the important thing in the aesthetic part of this. So you need to think about, when we're doing these full arch implant restorations, a lot of times people say, oh yeah, they're just dentures that's fixed in. Really, it is not. It's actually very complex, because we're actually combining complete denture concepts with fixed pros principles, right? So you're basically doing a full mouth rehab on fixed teeth. Basically, things are fixed in, but you still have to follow complete denture principle, because you have the ability to change pretty much everything. Fixed pros, a lot of times you don't have so much control about lip support and phonetics, not as extreme as dentures, right? Dentures, you have a control of all these things, but the occlusion in dentures is totally different than fixed. So in these type of restorations, you're actually combining fixed pros with complete dentures. So you can't just only do fixed and not know anything about dentures and expect to get good results doing these full arch restorations, and vice versa. You can't just purely do dentures and not how to do fixed pros and expect a good result, right? So these restorations are not just a denture screwed in. It is a complex fixed rehabilitation, restoring the patient's dentition and the alveolus, right? It's not just teeth now. You're actually replacing the patient's alveolus, right? Which affects speech, lip support, facial form. So you're looking at things like vertical dimension, incisal edge position, midline phonetics, cant. A lot of these things are actually related to dentures. So we look at a case like this. This dentist was trying to actually get something that the patient's gonna be able to tolerate. Unfortunately, this patient is a very poorly adaptive patient. The implants are already in. And if we look internally, it's in a retracted view, it's not so bad. But if we actually look back and look at the smile, we see there's a lot of things that needs to be altered here, right? The upper teeth are way too wide. There's no buccal corridor. There's a reverse curve. The upper anterior teeth are way too short. This patient's showing way too much lower teeth. The vertical dimension probably needs to be changed. We need more information to assess whether the vertical dimension needs to go increase or decrease. So this is the after. Now, it's easy to show before and after, but I can tell you, I spent many appointments for this patient to a point where it's literally financially not even worth it, right? Because there's a lot of things you gotta look into that you're trying to balance, right? Especially on a patient that's very non-adaptive. The implants are in, so we can't change the implant position. So we're now trying to connect implants to teeth, and we're trying to position teeth to make things okay for the patient, and we're trying to juggle all these things. On one side, we're trying to set the ideal vertical dimension, get the ideal support, lip support, good occlusal plane, good midline, good cants, no phonetic issues. But on the other side, you got to balance those factors with where the implants are, right? Where, based upon how much space you get, because you can't plastic the bone anymore. You can't get any more prosthetic space, right? And then there's also the subjective component to this, which is the patient. Like, is it comfortable? Some patients say, oh, this is too bulky. Even though you get ideal lip support, they feel so bulky. They can't clean it because now the more lip support, there are potentially more ledges, and then people can't clean it, right? And then you got to balance it with the occlusion and make it work. And then based on all that, you got to choose the proper materials so that it holds out, not break. So in a lot of situations, these types of restorations are easily done, right? Where the patient have a good reference, you have a good reference point, the previous teeth are in good position. You're really kind of just changing things out from natural teeth to prosthetic teeth. But you can easily get a situation where you have no reference anymore, right? There's a complete clean slate. You have to sort of reestablish everything. And it's even more complex when you can't even control where the implants go. So the next surface we're talking about of the prosthesis is the lingual or the palatal aspect. Most people don't care so much about this, but this actually is quite important in phonetics and comfort, okay, and a little bit hygiene. If the implants are placed too far lingual, right, and there's not enough bone reduction, sometimes these lingual aspects of these prostheses become very thick. And when the lingual of the upper teeth or the lingual of the lower teeth are very thick, it may affect speech. And if the patient can't adapt to it, you have a major problem, because now you can't make things thinner because that's where the implants are, and you can't obviously you can't move the implant, and the lab definitely has to connect the implants to the teeth. So what do, right? There's not many good solutions, right? Sometimes, obviously the implant needs to be deeper, right? If it's gonna be lingual, they have to go deeper, because if it's always pretty much on the palate, and the implant isn't placed deep enough, and you got to connect everything, there's going to be huge thickness, huge bulk on the palatal area, and the patient cannot tolerate. Sometimes they speak fine, but they feel like everything is too bulky and it's a comfort issue. So one strategy for that is actually designing using a metal substructure and making the lingual aspect as thin as possible in pure metal, and then the ceramic starts in a more anterior aspect. Phonetics is a major issue. Certain words is based upon where the patient positioned their teeth to their lip. Some phonetic words are based on the position of the patient's tongue relative to the teeth, or tongue relative to the soft tissue or the palatal area. And you really need to know how your prosthesis is going to affect different pronunciation of different words, right? And so when a patient is saying, oh, I'm lisping when I say S or T, you need to be able to sort of troubleshoot that and adjust your wax up or your teeth to solve that issue. Okay, and we see that problem all the time, right? Like a patient lisping, and lisping can actually be teeth, too short, too long. The back of the prosthesis could be too thick or too thin, right? All of those can cause lisping. So the last surface here is the intaglio surface, and the intaglio surface is largely responsible for hygiene, right, and long-term tissue health. The intaglio surface of the prosthesis can be one of three materials, right? It can be acrylic, zirconia, or titanium. Obviously, all of them should be, no matter what material, they should be highly polished. It should be as flat or concave as possible so things don't collect, and ideally off, hygiene space off the tissue. And it should be in a way so that things don't collect. And so sometimes you need to train the soft tissue or shape the soft tissue. In an ideal world, the soft tissue is adjusted by the surgeon or by your temporary restoration during healing. And sometimes it's done in the later phase where you do another adjunctive surgery to kind of shape it. Now, if the shape of the intaglio is now ideal, patient can keep it clean, then you can actually take impression or kind of put a light body impression material underneath that temporary prosthesis and put it onto the cast, and you basically redo the soft tissue aspect of that cast, okay, of the model. And so the lab, when they design the new prosthesis or the final restoration, they can actually scan this new soft tissue, and then they can actually do the negative image of this to actually design the intaglio surface exactly how your temporary restoration was. In some situations, not saying you have to do it 100% of the time, it may be beneficial to actually put in prototypes into the patient first, let them function for a few weeks before moving towards final, more expensive restoration. I highly recommend doing something like this if the patient has a lot of subjective concerns, like comfort issues, like they don't feel comfortable, things feel so bulky, I can't keep it clean, and you'll get an idea as to who these patients are. Sometimes you say, even though we did a wax try-in, there's a lot of things that you can't test out in an hour appointment, right? You have to sort of mill, PMMA prototypes, and these can be inserted into the mouth and let them use for a while. You can also use these as sort of like a medium-term prosthesis, where sometimes finances are an issue. You give these to the patient to use for 6 months or a year or 2 years until they have the finances to progress to the final restorations. And sometimes we do this for double jaw cases where someone wants to progress to the ceramic on the upper, but in the lower arch, they want to kind of save up and for 2 years before progressing to a final restoration on the bottom. So the next complication that occurs around 5% of the time is framework fracture, and that's straight up fracture of the titanium. This is rare, but I think that's related to sort of the positioning of implants. Okay, so we sort of have to look at where the implants need to go and where they should be, where they need to go biomechanically, right? So obviously upper jaw, the implants are usually limited by the sinus. On the lower jaw, they're usually limited by the mandibular nerve. Hence, the implants are angled to avoid that in cases where the posterior regions are deficient in bone. Okay? So the whole point of angling implants is to increase the spread of implants and to avoid vital anatomical structures and to potentially avoid bone grafting. But really the biomedical reason of angling implants is to get anterior posterior spread. You're trying to spread out the implants, right? The anterior posterior spread is very, very important in the prosthesis and determines how many teeth you can do. Okay, you can put in the final prosthesis. The further back the implants can go, generally the less cantilever is done in the prosthesis. And obviously the less cantilever, the better, right? Because cantilevers are bad biomechanically to the implants and the screws, okay, and the prosthesis. So anterior posterior spread is calculated by drawing two lines. The back line is between the most distal two implants on the most distal aspect of that implant platform, because that's where the prosthesis will fulcrum off of. And another line through the middle, okay, of the most anterior implant. And the AP spread is basically the horizontal, basically the perpendicular distance between these two lines. Basically, when the patient bites in the back at the cantilever, the prosthesis basically fulcrums and rocks on the distal aspect of the implants in the back, and the screw in the front prevents the lifting of that anterior segments. So the anterior posterior spread is calculated this way. Generally, the rule is in the mandible, the cantilever, how far back you can go to put more teeth, is 1.5 times this anterior posterior spread. On the maxilla is generally 1 to 1, okay? And in general, we should not go beyond 15 millimeters depending upon, regardless of, where the implants are, okay? If we're using pure zirconia, it's more important that you don't go beyond 15 millimeters in order to reduce the chance of the zirconia snapping. So if you look at this study, basically they're just kind of explaining that when the patient is biting in the posterior area in the cantilever region, the implant most adjacent to that biting area takes the most downward force, and then the most anterior implant gets actually some upward force. If there's a fifth implant, the most anterior middle implant does very little work, basically almost nothing. So that's kind of an argument of not doing more than 4 implants, because biomechanically the front implant doesn't do anything. However, in the mandible, the success rate of the implants and the prosthetics are not really related to the number of the implants placed in the jaw. Therefore, in the mandible, with a high, with an implant survival rate of 98 to 99% at 10 years, it may be more likely that you can do 4 implants only. On the maxilla, however, the survival rates of the prosthesis is actually a little bit better, given that based upon the positioning of the implants. Okay, so the prosthetic survival is at 1 year is 98%, and 92% is at 10 years, and it was influenced by the number and distribution of the implants. So it may make sense to put more than 4 implants on the upper jaw, even if the front implant doesn't do much work. However, but don't forget that there's anterior cantilever. So when the patient is biting in the front, if there's an implant more anterior, you're reducing anterior cantilever. So remember I showed you a case way back where there's a huge discrepancy between where the front teeth needs to go and where the implant needs to be. Sometimes that front implant reduces the cantilever forward. If you decrease cantilevers, you're reducing the chance of screw complications, of things loosening up or things breaking. There's also, if you're doing more than 4 implants, there's redundancy of implants, right? So if you're doing 4, if one implant fail, the whole thing needs to be redone. If there are 5 or 6 implants, sometimes you just unscrew the prosthesis, take out the failed implant, you modify the prosthesis a little bit, and you reinsert the same prosthesis, and it's done. Okay, so sometimes most patients choose to put additional implants for contingency. Maybe 4 is okay on the mandible. On the upper jaw, it might be better doing more implants. And you also look into consider the cost of the prosthesis, right? If you're doing very, very complex, titanium, ceramic restorations with individual crowns with a high lab fee, maybe plan some extra implants in there in case something fails down the road. Okay, so that you don't have to redo everything. So the proper bar design is very important in preventing bar fractures, right? So positioning of the implant is important. The bar design is also very important. So making sure the bar is tall enough, right? Minimum 3 to 4 millimeters in height. It supports the occlusal surfaces, and making things thick enough, okay? So adequate space, adequate acrylic thickness, so your bar can actually have enough space to be the 3 to 4 or even 5 millimeters in height. So the last type of complications in the full arch restoration is abutment screw fractures or loosening, so screw issues. Very low chance of things happening with the screw when in full arch restorations, because everything is splinted, right? So if everything is passive, the chances of screw loosening is actually very, very low. So passivity is key in preventing screw loosening. And so how do we get things to be passive is really doing good records, good impressions, and verifying. So generally, what I do is when we're about to take a final impression, we retorque all the abutments, which may have loosened during the healing phase, or sometimes more commonly is the abutments were tightened or torqued on the day of surgery, but there was some soft tissue or hard tissue that was kind of preventing the abutment from actually tightening all the way. So you got to torque in all the abutments, because if the abutment is not torqued and you take the impression to make the final prosthesis and then realize afterwards that the abutment is loose, you then go back and tighten the abutment and the abutment actually sinks down a little bit deeper, your prosthesis is not going to fit. And so that's a big problem. So you should definitely retorque the final the multi-unit abutments right before impression or scanning. Custom trays, if you're taking impressions, the tray can actually influence how well things fit. If you're using custom trays, which saves you materials and supposedly make things more accurate, you got to be aware of when the lab makes you that tray, because if they're using triad, there's studies that show that the tray material will actually shrink over the next 24 hours. So if you have an in-house lab, or if you're getting your assistant to make you these trays, or whoever's making these trays in office, like right before the impression, you cure it, you take an impression, you send it to the lab, they pour the model like 24 hours later, the tray is actually going to continue to shrink and actually cause it distortion. If you're taking impressions, tray adhesive, so PVS tray adhesive is highly recommended, because studies show actually if you don't use tray adhesive, the PVS will actually shrink away from the tray and also cause distortion. So highly recommend using tray adhesive. If you're using custom trays using Triad, they should actually be made well in advance, like a day before. The other option is just to not use custom trays and use very common, or these are called mirror mar trays, which are kind of like these trays that have like sort of like saran wrap on the occlusal surface, so the impression copings kind of just poke through the trays. Splinting impression copings in full arch cases for the impression, it has been shown to be beneficial, is more accurate, but you have to sort of look at how you are splinting the impression copings, the technique and the material used. The most common recommendation is to use GC pattern resin or Duralay to kind of splint impression copings together. Like in this video, I borrowed this video from Dr. Seller, and basically very common method is to use floss to kind of join the impression copings together, and then using pattern resin to splint them together. You generally want to wait like a good 10 minutes for things to set and to shrink, because these material will shrink, and then go back in and section them to relieve the stresses from the shrinkage, and then rejoin them. Okay, therefore then the shrinkage is now a small percentage of those cuts. Okay, so overall much less shrinkage overall. So compared to pattern resin compared to Duralay, okay, pattern resin actually shrinks less than Duralay. Okay, so we're using one of the two. Pattern resin is better by GC. Another is to use composite. So I use composite because it actually shrinks better, shrinks less. And the main benefit is not really related to the shrinkage, is related to the actual time. Okay, time, because you don't have to wait 10 minutes for things to shrink. Okay, if you're gonna splint and you're not sectioning things and then rejoining, or if you're not waiting for things to shrink before the impression, the splinting process will actually increase your errors, actually. Because if you look at the shrinkage of PVS shrinks much less than pattern resin. Okay, so if you're using something that's going to shrink more than PVS and you're not waiting to compensate for the shrinkage, you're better off not splinting, right? Which is not my point. The point is the splinting is supposed to get increased accuracy and have more accuracy compared to even PVS. So composite can be cured and you don't have to wait. What's a very simple, cost-effective way to splint things more accurately is to use things that don't shrink, aka old burrs, right? A metal burr is not going to shrink, and so I utilize composite to join burrs in the mouth. It's fast. Use a composite that has that shade that you never use. Potentially even use composite that you're about to throw away because they're recently expired or whatever. Using composite that is just using it to join burrs together. I generally ding up the burrs so that it's kind of rough, and you cure it. If everything is joined together, I then take a open tray impression, right? So now these burrs are now splinting the impression copings together, and it's actually more accurate than the PVS, which will shrink a little bit. Once the model is poured by the lab, no matter how good your impression is, you generally want to verify to make sure that your impression was indeed accurate, or the pouring of the model or the model fabrication is actually accurate. So you always want to do a verification, and you should get the lab to make you a jig, okay? And usually most jigs are made in acrylic, which again will shrink. So the lab or you should actually section the jig and rejoin. So as a general rule, you want to verify in the mouth, meaning you don't want to kind of put the jig in the mouth and kind of look in the mouth. You want to put the jig in the mouth, section it in the mouth, tighten everything in the mouth, rejoin the jig in the mouth, and then remove the jig and check for the fit on the model. Because on the model, you can actually remove the soft tissue. There's now no saliva, there's no soft tissue or anything like that. You can actually look very clearly 360 if things are actually all seated. In the mouth, sometimes there's saliva, there could be blood, there could be plaque, there could be soft tissue holding it. You kind of can't see as clear. So you want to always section and rejoin in the mouth and check on the model. On the model, you can do the one screw test, right, where you screw in one screw and see if things are lifting off. And if something is inaccurate, you don't necessarily have to retake impressions. If there are 4 implants or 5 implants or multiple implants, if you can actually decipher which one is not accurate, you can actually dig out the 1 or 2 analogs and screw the analogs back onto the jig, screw the jig onto the rest of the implants, and actually reposition the analog in the stone cast, utilizing more stone or pattern resin, or flowable. Obviously, you got to dig out a hole big enough so that the analog can actually fit in passively. If you can't figure out which analog is off, then sometimes maybe best to just retake impressions. That technique can also be done for bridges, not necessarily full mouth, as long as there's at least 2 implants that are accurate. Because if you're using non-engaging impression copings, if you have 2 implants only and one is inaccurate, when you dig out one analog, the jig is going to rotate 360. You don't know how it is because it's non-engaging, right? But if you have 3 implants and one's off, you can actually reposition one of them. So in this case, we put this jig on. We realize, okay, like this left implant on the far left is actually not seated. Like there's a gap between the analog and the impression coping. You can dig it out, like on the right side where there's a hole now. You can actually screw on the analog onto the jig and then just reposition that analog. So this is repositioned with just flowable. That way you don't have to retake impressions so that your patients are not going to question and be like, hey, why are you redoing what we did last time? So that's kind of like the most common issues we see with full arch fixed restorations on implants. The last part of this lecture is talking about removable prostheses. And this part is much faster because a lot of these are related to dentures. So, most people here should know how to sort of troubleshoot denture issues. By far, the most common issue with removable pros which occurs apparently 159% of the time, meaning the complication occurs more than once for somebody, okay? Which is, I'm sure if you do dentures, you have experienced this yourself, right? Where the patient's going to come back again and again for denture adjustments. So I'm not going to talk about how to fix it. You do denture adjustment, you do sore spots, occlusal issues, stuff like that. The next one is overdenture attachment issues, right? Such as locators loosening or wearing down or distorting and they can't go in. So the most common, system I would say is the locator system, right? It's easily changeable, it's very easy to use. Most dentists know how to use them, most labs will do it. Internationally, everybody should know what locators are. So locator abutments should be as low as possible, right? But still stick up 1.5 millimeters above the soft tissue, right? You don't want a locator abutment that's like kind of sticking up 5 millimeters above the soft tissue, mainly because if it's sticking up so high, your prosthesis is going to have less space. Like things are going to be thinner, things are going to snap, right? Parallel implants here, where it's going to play a role in how long things last, because parallel implants are going to allow more parallel fit of the prosthesis, and the nylon inserts of the locator are going to wear down slower. If the implants are not parallel, there are non-parallel nylon inserts by locators, and those are the ones without the male component in the prosthesis in the nylon. It's the green, the red, and the orange color. One further way to compensate for the shrinkage of the denture causing misfit is to potentially pick up the locator housings intraorally. So I don't actually get the lab to process the housings when they do it. I get them to leave a space, make the denture, and then I pick up the housings intraorally using a direct method, right? Because if the denture shrinks, which we know it will, if the housings are already picked up together, it's going to pull the housings closer together. Some labs will know this and will actually pick up the housings after the denture has been made on the model. I still don't like that, because when the denture is broken out of the model, out of the flask, okay, there's going to be shrinkage. The denture will never fit back onto the stone model as nicely. And therefore, if they pick up the locator housings on the model, is never going to be the same in the mouth. So I always just pick it up in the mouth. Another way to reduce, attachment issues is actually positioning of the implants and the number of implants. So for the mandible, very typical is 2 implants On the maxilla, if we're doing overdentures, we need 4 implants. Okay? Anything less than 4 substantially reduces the survival rate of the prosthesis. So maxilla minimally needs 4 implants. Mandible should be ideally 2. You can do more, right? Sometimes you do 4 implants for overdentures. The more implants, obviously, the more retentive, but more costly. If you do 4 implants, why don't do fixed? Sometimes, however, it's a staging issue, right? Sometimes the patients say, let's do 4 implants, get the surgery done, get a removable overdenture first, and then down the road progress to a fixed restoration. So sometimes that happens. The positioning of the implant, if we're doing overdentures, most people would put them at the canine position. I would argue the ideal position is actually the lateral position on the mandible. There's several reasons. One is if the implants are in the lateral positions, there's usually now enough bone and space between that implant and the mental foramen. If the patient then later on decides to do fixed, 2 more implants can be done posteriorly. That's a major benefit. If the implants are now on the canine sites and they say, look, I want to do fixed, where are you going to position the distal implants, right? It's a problem. Biomechanically, putting the implants on the lateral position is actually better than the canine. You would think that the implants are better further back. Actually, biomechanically, it is not. When the implants are placed in the canine sites, the denture can actually rock back and forth and folk seesaws on top of those abutments, okay? Because over time, the ridge is going to resorb in the anterior, the ridge is going to resorb on the posterior. When the patient bites, even though they're not supposed to bite in the front, most patients will, and the denture is going to basically seesaw around the canine implants. So that's what we call a class 1 lever system, and they bite hard enough, the denture can crack in half, and most patients will just complain that the denture is just rocking back and forth. If the implants are placed anterior at the lateral sites, this is what we call a class 3 lever system, because the implants so far forward, the denture can't actually rotate forward, can't rock forward. The denture just basically rotates back. The lever system is class 3, which is a wheelbarrow. It's way more favorable for the implants in terms of forces. And as the ridge resorbs in the back, all you have to do is realign the denture. The last benefit of putting implants on the lateral sites on the mandible is for space, okay? So canines are already bigger teeth. There's usually canine eminence, and sometimes if there's implants there and there's a housing, there's the room for the abutments, it just gets so thick at the canine site, and sometimes the lapices sort of trim away so much of the canine. They're just bigger teeth, right? So there's just less space for all the componentries. So that's my suggestion, is that putting the implants on the lateral sites. Getting close here to the end, overdenture fractures, basically talking about the entire prosthesis snapping in half, happens 9% of the time. One very simple way to prevent this is putting a metal substructure in the overdenture, right? On the upper jaw. Most people already do this. If their implants are on the canine or premolar sites, upper overdentures can be made in a horseshoe fashion. If you're afraid of the denture snapping at the midline, then it's ideal to have a metal casted substructure underneath it. On the mandible, generally not necessary, but if the patient bites hard, if there's not a lot of reduction, if there's not a lot of ridge resorption, the prosthesis is not very thick, sometimes you can also do a mandibular metal substructure underneath, kind of embedded inside the overdenture. Obviously, this adds more cost, adds more space, but it will prevent fracture of the prosthesis in half. However, it does not prevent denture teeth breaking, and it doesn't prevent denture fractures, okay? Acrylic fractures. If you actually add a metal substructure, the acrylic is actually weaker, okay? Because you're actually utilizing some of that space to do metal. By the time the metal actually takes on some forces, the acrylic has probably cracked already. The major benefit of the metal substructure is so that if things crack, things are still joined together. So it's easier to repair and things aren't completely separate in two pieces. If there's no metal frame inside, sometimes the patient will come and give you literally two pieces of a denture. So it's more of a catastrophic / traumatic break. The next issue is phonetics with removable prosthesis, and usually that's related to the upper prosthesis. If the upper anterior ridge has not resorbed substantially, and you're not planning on doing a lot of ridge reduction, my recommendation is to avoid putting implants anterior to the canines, because that affects speech a lot. And if you put implants into the canine, for example, the lateral or the central areas, and you don't put them deep enough, or the patient is not able to tolerate extra thickness there, then you have a very difficult situation, because there's an implant there. You need to connect it and the patient can't speak. So you gotta be careful putting implants anterior to the canines. In severely resorbed cases where the acrylic there is gonna be super thick, there's tons of space, then maybe you can. But biomechanically and phonetically, the implant should go further back anyways on the maxilla. Bar issues with removable prosthesis. Now, I don't personally do a lot of bars for removable prosthesis because there's a lot of actually disadvantages to it with minimal upside. So studies show that bar overdentures does not significantly improve patient satisfaction compared to individual attachments such as locators on an overdenture. So if it doesn't drastically increase patient satisfaction, why spend more money, make the case more complex and more difficult to do? Bars increase cost, increase difficulty, requires more space, more difficult maintenance, and it's also harder to manage if implants fail. There is some literature that will report that splinting the implants with the bar on the maxilla for an overdenture is going to increase the chance of implant success, whereas individual attachments have a lower success rate of the implants. But if you use a bar and you're joining all the implants together, if one or two of the implants fail, that bar is essentially garbage. You can't really reuse that bar, and you got to redo the bar. Whereas if you do individual attachments and actually one or two or three or four implants fail, you can actually put new implants in and just pick up that locator housing using the same prosthesis. So it's a very easy fix and patients don't have to redo the whole prosthesis, right? So even though the implant survival rate may be a little lower having individual attachments, if it does in fact fail, it's a very simple fix. The patient gets a new implant, 3-4 months later, you come back and you pick up the housing for the new implant. So I only use bars for overdentures if there are major angulation issues. The four implants or the implants are not parallel. You can't even do locators on those implants with individual attachments. Then it may be necessary to do a bar to connect all the implants and to sort of reangulate the locators. So that's sort of a good summary of all the most common complications reported in the literature. And we went through sort of one at a time to kind of go over sort of like what causes these issues and how to prevent some of these issues, and sometimes how to actually fix these issues. Ranging from single teeth to multiple teeth to full arch, fixed or removable. And I would imagine that as time goes on, we will expect to see different types of complications arise that are not reported in the literature. So thanks for your attention. I know it's a long lecture. If you have any questions, feel free to email me or to reach out. A good way to reach out is to talk to me through Instagram. And I'm probably on Instagram more so than on my email. Feel free to reach out if you have any questions.